everyone. My name is Dr. David, also known as Margarita. Today we're going to discuss IV fluids, which seems to be a big concern among students. Now, there are three classifications of fluids, which are inclusive of isotonic, hypotonic, and hypertonic. I'm going to write them down. So you have isotonic fluids, you have hypotonic fluids, and you have hypertonic fluids. It is very important, like I said in my previous introductory video, to understand the pathophysiology of each. You cannot understand something for retention if you only memorize it. So with the isotonic fluid, hypotonic fluid, and hypertonic fluid, they each do a different thing. One big concern from students is, how does it work? So when you have fluids being given to a patient, it does a function. So depending on which one of these three it is going to do a particular action. So an easier way to remember it is, with isotonic, okay, you take the letter I, and we're going to pretend that this is a vessel. Okay, so in here you have blood, which is the circulating volume. And then here you have your cells that are outside of the vessel. So this could be your vein, artery. So for example, when somebody drew labs on a patient, that's where they were able to get, is their potassium a certain level? Is there sodium a certain level? Is there calcium, their magnesium, their phosphorus, all those electrolytes? They're able to determine if they need to get an isotonic, hypotonic, or hypertonic solution. That is how they make the determination. There's a specific difference though. With isotonic solutions, whenever I give an IV fluid that is isotonic, and this is the IV bag, let's pretend, and this is a little tubing that's attached to the vessel of the patient. So when this isotonic fluid comes into the vessel, hence the letter I, it's going to stay inside. There's not going to be a shift from the vessel, which has the circulating volume, into your cells at all. This is for increasing circulating volume. What are some instances where you would need an increase in circulating volume? Well, maybe the person's blood pressure is low. So during hypotension, where the circulating volume is low, therefore they're going to need more fluids in order to be able to maintain a proper blood pressure reading. Okay? In other instances where there's a hemorrhage, they're also going to need isotonic fluids in order to maintain the circulating volume. The idea is, and the key word to remember from this is that an isotonic fluid stays inside the vessel. There is no electrolyte imbalance, which is the key to remembering what this is. So there is no electrolyte imbalance. Therefore, again, it's just to maintain the volume of blood. Okay? So the electrolytes that are inclusive in your cells, as well as the electrolytes that are in your blood, are equal. These are equal. Now we're going to move on to hypotonic. At the end of the discussion of all three, I will inform you which are which. Which one is a D5, which one's a 0.9 normal saline, so we'll go over that. So in hypotonic solution, using the same idea, so this is your vessel with blood, and these are your cells outside of the vessel, So an IV fluid bag is hanging here for your patient. This is the tubing, and this is connected to your patient. So what I want you to remember is that in hypotonic solutions, the O symbolizes that whatever fluid is considered a hypotonic solution is going to come into the blood vessel, which is your circulating volume, and is going to come out. So O is for out. What does this do? So when you have this fluid that is a hypotonic solution coming into your vessel and shifting to your cells and your tissues, that means that there is an electrolyte imbalance, which is different than when you have an isotonic solution, which is not an imbalance present. So here you might have an electrolyte that's either high or low, depending is what's going to determine which of these two, either hypotonic or hypertonic, you will get. So in this situation, I might have a patient that has, for example, hypernatremia. When I am talking about electrolytes, either high or low, in this example, it's sodium, hypernatremia, which is high, I am talking about the amount of electrolytes that is inside the blood, just like I said here before, okay? I am not referring to what's outside, because when you get blood drawn, they can only measure what is in your blood. So in this case, in a patient that has too much sodium roaming around, they will probably get a hypotonic solution, because the fluid will come in and it's going to allow the electrolyte to balance out, because it's going to come out of the blood vessel. So the amount of sodium in the circulating volume is going to shift to your tissues and your cells in order to create a balance between the outside and the inside. So that's an example of, let's say, hypernatremia. The major difference between an isotonic and a hypotonic solution is that hypotonic solution is pure water. An isotonic solution provides calories, which is why you see isotonic solutions being used in, let's say, a preoperative setting like same-day surgery, where the patient has been NPO or nothing to eat or drink since midnight the night before. So they need some type of nourishment, okay? But here in the hypotonic solutions, the fluids that are inclusive of this are just considered water. In hypertonic solutions, let's use the same vessel. This is your blood vessel, and this is your IV fluid bag. This is your tubing connected to the patient. So in this example, we're going to take the E in hypertonic, and that means enter. So the fluid that's coming in, that is a hypertonic solution, is going to come into the blood, but these tissues and cells, the action that's going to happen is that is going to draw out from the tissues and cells into your blood vessel. So the E means enter. So it's going to enter. So if I'm going to give a hypertonic solution, the expectation is that I'm going to release some of the extra circulating volume or electrolytes from the tissues and cells and bring it into the circulating volume in order for it to later be excreted through your kidneys, okay? So what is a potential patient situation for this? Well, how about if you have a patient that has hyponatremia, which is low sodium level? So in hypernatremia, it means that there is less sodium in the circulating volume than in your tissues and cells. Therefore, we must create a balance. So the fluids that I am getting is going to draw out some from the cells into the circulating volume in order to create that balance. Because now we have more outside of the vessel than we have in. Another patient situation that you can find is someone that has edema. If I have a patient that has edema, I'm trying to decrease the fluid that's in their tissues and put it back in circulation. So I'm also going to be putting them in a hypertonic fluid, so it can draw out the fluid from the tissues into your vessel. Now to talk about the different type of patient scenarios that you might encounter. So for isotonic solutions, there are two patient situations that you may not give this solution to. For example, some of the solutions that fall under isotonic solution are 0.9 normal saline, lactated ringers, and D5W. So 0.9 normal saline, lactated ringers, and D5W fall under isotonic solution. Now there is a tricky one in here, which is your D5W. D5W is also considered a hypotonic solution, but we're going to talk about that in a couple minutes. So there are two patient populations that should not get lactated ringers. These are, based on the word lactate, where is lactate metabolized? Lactate is metabolized in the liver. So liver patients should not get lactated ringers because they cannot metabolize it. So if a patient has liver failure, they cannot get lactated ringers. Another population that cannot get lactated ringers is your kidney patients that are on dialysis or going through the process and stages of acute renal failure, chronic or acute. They cannot have lactated ringers because it includes several electrolytes, including potassium, that is already elevated in these patients, and that if they increase even further can cause some cardiac issues. So lactated ringers cannot be given to either liver patients or kidney patients because liver patients are unable to metabolize lactate and kidney patients are unable to get more of the electrolytes that they already have elevated. Now going back to 0.9 normal saline. 0.9 normal saline would be the choice for these type of patients. So if a patient is coming into the hospital for an admission, a procedure, a surgical intervention, usually in the pre-op area and same-day surgery, we would provide them with lactated ringers because, how I said in the beginning, it provides some calories. But for the kidney and liver patients, they are unable to tolerate this. So those patients are put on 0.9 normal saline. Specifically, renal patients, your kidney patients, they are placed on 0.9, but they have to be monitored because they cannot get too much of it because as they have dialysis or they are in the process of getting to that stage, they are unable to filter out the extra fluid. So they can get edematous, which is swollen. Now, when they are placed on 0.9 normal saline, you have to monitor them closely, just like you would if a person comes in with a history of congestive heart failure, also known as CHF, or have a history of fluid overload. They already have too much fluid volume. So if we don't monitor them closely with 0.9 normal saline, they can get into a worse situation and the volume can increase. So to review, lactated ringers are not given to liver or kidney patients. It is substituted with 0.9 normal saline, but 0.9 normal saline for your kidney patients have to be monitored because it can provide too much fluid volume. Also for the patients with congestive heart failure or fluid overload, you have to keep a close eye because it can make their situation worse. Now going back as to why D5W changes to a hypotonic solution, because this is your tricky fluid. So I'm going to write tricky. The muscles and your tissues can only retain 5% of sugar at one time. So the moment that happens, when you have an isotonic solution like D5 being given to a patient, the body takes in the 5% of sugar, which is 5% of dextrose. The D means dextrose or sugar, glucose. And this 5 is 5%, and the W is water. It turns into water. So the minute that it does that, it becomes a hypotonic solution, pure water. Some hypotonic solutions include 0.45 normal saline, 0.33 normal saline, and how we just talked about D5. Because they are water. They do not provide any calories to the patient. So to review, the hypotonic solution that you give, either 0.45, 0.33, or D5, goes into the circulating volume and comes out. O for out, because it is trying to feed your tissues and cells. Another time that you may see this fluid being given is someone that is dehydrated, but they have an electrolyte imbalance. So what are you trying to do? You're trying to feed those tissues and cells so they can plump up. However, if they plump up too much, it can burst. So you have to monitor these patients closely as well. Now, the D5W is contraindicated in certain populations. But I'm going to include the entire hypotonic classification in this, in one of the two. One of the populations is patients with, and I'm going to draw a brain here as best as I can in the stem, with brain injury. And that includes someone that has cerebral edema, where there's swelling of the brain. So if you remember the path, though, of hypotonic solutions, and you know that 0.45 normal saline, 0.33 normal saline, and D5W go into the circulating volume and then shifts to the cells and tissues. If I were to give this to someone that has brain injury, like cerebral edema, increased intracranial pressure, I'm going to make the situation worse. Therefore, hypotonic solutions are contraindicated in patients with brain injury. A second population that this classification is contraindicated in is infants. Because of two reasons. One, the anterior and posterior fontanelles are still open, so they can cause hydrocephalus. And two, the body mass of the infant is small as compared to the amount of water than someone that's an adult that has less water and more body mass. Therefore, you can cause a severe problem, including hydrocephalus, if given to patients. So infants do not get hypotonic solutions. So that is why D5 is considered both an isotonic and a hypotonic solution. And these populations you need to be very careful with, because if you see a patient that has any of these issues, either liver failure or kidney failure, and you see them with lactated ringers, you need to question that, because they're supposed to be on 0.9 normal saline. Now we're going to move on to hypertonic. So we discussed earlier that a hypertonic solution goes into the circulating volume with the intention of having fluid draw into the circulating volume. So with the E for enter, so any excess volume, excess electrolyte is going to go from the tissues into your blood vessel. Some of these fluids include your mixed fluids. For example, D5 lactated ringers, D5 half normal saline, D5.9, and any combination available, plus D10. So if any patient is receiving any of these fluids, the intention is, one, they might have edema, too much fluid in their tissues, so you're drawing them out, or they might have a deficiency in an electrolyte, and being that there is electrolytes in the tissues and cells, you want to balance them out, okay? And in D10, I get that question as to, oh, why is it that D10 is not like D5? Why is it classified as a hypertonic solution as opposed to an isotonic and a hypotonic? Well, remember what I said in the beginning. The tissues can only take in 5% of sugar at one time. Therefore, when you're giving 10% of dextrose in water, there's an additional 5% roaming. This fluid is given when a patient is getting total parenteral nutrition, or when they're getting PPN. For example, if there's a delay in mixing the TPN from pharmacy or wherever they get it in the hospital, the patient cannot be left without a sugar source. It's just like when you're hungry and you go ahead and you eat some type of chocolate bar, a candy bar, and your sugar rises, but then what happens? You crash. So we cannot have patients do that. So in order to maintain a steady glucose level in your blood, we must give the patient something to hold them onto the fluid, special fluid, the TPN, is given to the patient. So what we're going to do is that we're going to hang D10W at the same rate as the TPN was given. So if the TPN was given at 83 cc's or mLs per hour, the D10 is going to be given at 83 mLs per hour until the bag is brought up and the patient can receive their TPN. That's when you put this. As soon as you just want to take this down and put the new bag. So this is used in those types of situations. We have to be careful because there are patients that are diabetics, and this is given an extra glucose to them, and it can raise their blood sugar, meaning that they're going to probably need more medications to lower it, for example, insulin. That can also happen when a diabetic patient is receiving D5W because it's, again, providing more sugar. So patients that are diabetic, you want to make sure that you monitor them closely and check their blood sugar to make sure that it's not too high. So just to review, isotonic fluids include 0.9 normal saline, lactated ringers, and D5W. This is given to patients that have no electrolyte imbalance. So there is no shift from here, from the blood into the tissues. It is just to maintain circulating volume. For example, if somebody has low blood pressure, hypertension, is going through a hemorrhage, and it also provides calories. So if you have a patient that has been vomiting, has had GI issues with no electrolyte imbalance, which is known when the blood is drawn from the patient, they're going to get an isotonic solution. D5 is also a hypotonic because as soon as the tissues take in 5% of the sugar that's in, or dextrose, it becomes water. In hypotonic solutions, remember the O, so the fluid goes into the circulating volume and comes out of the volume into the tissues. It's trying to feed those tissues that might be dehydrated with an electrolyte imbalance. Maybe there's too much of an electrolyte in the blood and you're trying to shift it into the cells to dilute. But those are the instances that you would give that, which include 0.45 normal saline, 0.33 normal saline, and again, the D5W. Hypotonic solutions are contraindicated because of this pathophysiology in patients that have brain injury, and also infants, because infants, one, the size, they have too much water for their body mass, and two, the fontanelles, both anterior and posterior, are open, so they can be at risk of hydrocephalus. Then you have the hypertonic solutions, which the E, you're going to be given the IV fluid and it's going to enter the blood vessel, but the extra volume is going to go from the cells and enter your blood circulating volume. This is the case of somebody that might be edematous. They might have too much fluid in their tissue, so you're trying to draw it out. And these include D5 lactated ringers, D5 half normal saline, and D5.9. Also, you might see them with, when they add potassium to it, like 20 MEQs. So any combination is considered a hypertonic solution plus D10 because you want in patients that receive parenteral nutrition to continue to have the steady glucose level. Therefore, as it has an extra 5% of dextrose, it's going to maintain that until they get their proper nutrition. And you have albumin, which is usually given to patients that have had burns or suffer from third spacing. Usually you will see also these patients with liver failure where they have ascites, and they have to replenish this, especially when they go through a process of paracentesis where they remove the extra fluid volume from the abdominal region. So this is the lesson on IV fluids. I'm going to step back so that you can get a clear look at it. I know there's a lot going on here, but it's going to give a really good synopsis on what IV fluids and the importance that each of these classifications have, as well as what they do inside a patient's body, because I do get this question a lot from students. Why is it that the patient who has edema is getting certain type of fluids? Well, somebody that has edema is getting hypertonic solution, like D5 lactated ringers, for example, because the function is to draw out that extra fluid. So hopefully this clarified a lot of your questions, but if you have any additional questions, make sure to put them in the comments below, and I will try to answer them as much as I can. And look forward to the next video where I'm going to go into detail regarding electrolyte imbalances. Thank you for your time. Have a nice day.